Welcome back to Ronnie, I'm Joe B. Today I'll show you how to correct a flexed sacrum or a sacrum stuck in a nutated position. Let's dive in. A flexed sacrum is when the sacral base tilts anteriorly while the inferior lateral angles deviate posteriorly and get stuck there. To treat a flexed sacrum, position the patient in sitting with hips and knees 90 degrees flexed, feet together, and flat on the floor. The therapist can be on either side, whichever hand is dominant. In this case, the left hand, so the therapist is on the right side of the patient. The left heel of the hand is placed on the sacral apex, while the right hand is placed on the mid-thoracic spine. The patient is asked to internally rotate the hips and flex the trunk first. Once attained, the patient is asked to inhale, and upon exhalation, the patient is instructed to extend the trunk against the therapist's right hand resistance. The left heel of the hand provides an anterior pressure on the sacral apex. The position is held for 6 seconds for 3 to 5 reps, gaining more trunk flexion each rep. This mobilization can also be done in prone, which we'll discuss in another video. Hook lying, prone, seated, or standing posterior pelvic tilt exercises can be provided for the patient to reduce or eliminate likelihood of sway back posture or flexed sacrum recurrence. This is performed for 2 sets of 10 reps and eventually progressed with addition of hold times. And wait, there's more. Stand to sit exercises can also stimulate the flexed sacrum to move into extension due to occurrence of hip flexion, posterior iliac rotation, sacral extension, and decreased lumbar lordosis during the activity. The assessment for a flexed sacrum requires the patient to do sacral extension, since inability to do it confirms that the sacrum is stuck flexed. There are 2 bony landmarks to palpate: the sacral basis and the inferior lateral angles. To palpate the sacral basis, the patient must be in a relaxed, erect short sitting with hands across the shoulders and feet flat on the floor. The therapist should be behind the patient with eye level at the sacral base or L5 spinous process. The first web space of both hands palpates the iliac crest first, then the thumbs reach down and medially to palpate the posterior superior iliac spine or PSIS. From there, the thumbs go up and medially by 1 finger breadth to arrive at the sacral basis. After that, patient is instructed to slouch the low back, resulting to sacral extension. Normal findings are that sacral basis move posteriorly or becomes shallow. Abnormal findings are that sacral basis stay anterior or deep instead of normally moving posteriorly or becoming shallow. To palpate the inferior lateral angles or ILAs, the patient and therapist position will be the same as with the palpation of the sacral basis. Both thumbs will slide down from the iliac crest to the PSIS. Then the dominant thumb palpates the S2 spinous process, then S3 and S4. Once S4 is reached, the thumbs will go 2 to 3 finger breadths inferiorly and laterally to arrive at the ILAs. The patient is then asked to slouch the low back, which results to sacral extension and lumbar flexion. Normal findings are that the ILAs move anteriorly or becomes deep under your palpating thumbs. Abnormal findings are that the ILAs stay posteriorly or becomes shallow. The cause of this can be due to a prolonged standing posture with globular protruding abdomen, and any pathology that can result to an increased lumbar lordosis or a sway back posture. A flexed sacrum can bring about localized nagging pain at the sacral region above the ischial tuberosity. There's also a feeling of buttock tightness and presence of a sway back posture or increased lordosis. So do you want to know how to correct an extended sacrum? If so, then watch this next video. Thank you so much.